Education, Labor, and Pensions Committee will please come to order. Today we are having a hearing on the federal response to the monkeypox outbreaks as we work to stop the spread of this virus. I will have an opening statement followed by Senator Burr, and then we will introduce our witnesses. Before we start, I do want to take a moment to congratulate one of our witnesses, Dr. Fauci, on announcing his upcoming retirement. Dr. Fauci, you have served through multiple decades and presidents and public health threats and worked to save countless lives. And I hope you know that you have the thanks of a grateful nation for your incredible service to this country. So thank you, and thank you for being here today. So after the witnesses give their testimony, senators will each have 5 minutes for a round of questions. And while we are unable again to have this hearing fully open to the public or media for in-person attendance, live video is available on our committee website at help.senate.gov. If anyone is in need of accommodations, including closed captioning, please reach out to the committee or the Office of Congressional Accessibility Services. According to the Centers for Disease Control and Prevention, the U.S. now has over 21,000 confirmed cases of monkeypox, more than anyone else in the world. And my home state of Washington has over 500 cases. I've heard from families who are rightly concerned about how bad this has gotten, and public health officials, including back in Washington state, who are frustrated to see the response run into issues we should be prepared for by now. That's why I have continued to push the Biden administration about my concerns with the monkeypox response and urge quick action on testing, on treatments, on vaccines, and on clear guidance to the public, to our healthcare providers and state public health officials. It is reassuring to see that we are making progress. On testing, capacity has increased 1,000%, and FDA just approved a faster track for additional tests. On vaccines, BARDA is helping to stand up a new vaccine fill and finish site in Michigan. HHS is working to expand the number of distribution sites in states, and the administration's advice for splitting doses has greatly stretched our vaccine supply. On outreach, the administration has started working with states to make vaccines available at events with many people from the Lgbtq community in attendance. And perhaps most importantly, the rate of new cases is going down. Now that's all encouraging news, but let me be clear, we must remain vigilant in our response. And these promising improvements do not excuse the issues I've been hearing about from communities, from state health officials and advocates from the very start of this outbreak. Patients have spoken out about how hard it is to get tested. Some even waited days despite having clear symptoms. Providers have had to jump through hoops to get their patients treatments. And I'm constantly talking to public health officials in my state who have told me how communications with states could have been far clearer and faster, and how the challenges in accessing tests and vaccines have delayed the response. I know states have especially struggled with the federal government's decision to forego the system we typically use to distribute vaccines, the one we are already using for COVID vaccines. When it comes to vaccine distribution, some shipments have been sent to the wrong state and even spoiled after storage at the wrong temperature. There have been issues with vaccine supply as well, like when thousands of vaccine doses were delayed because FDA had yet to inspect the new plant they were coming from, or when the Biden administration missed an opportunity to procure more vaccines at a crucial point in this outbreak. And again, we are seeing inequities worsen this outbreak for some communities. Advocates in the LGBTQ community who have faced the vast majority of cases have also made clear they feel they are being overlooked or in some instances stigmatized. We need to keep focusing and improving on outreach and on getting information and resources like vaccines to those who are most in need and most at risk. And that must include communities of color who we know do not have equitable access to vaccines. This is especially important as early data suggests that Black and Latino communities are disproportionately burdened by this outbreak. We have to do better. We need to be applying what we learned from the COVID response and providing the resources communities have made clear they need. Of course, there is an enormous difference between this and the COVID pandemic, which is, thanks to decades of investment in smallpox research, we already had tests and treatments and vaccines ready to go before this crisis began. That should serve as a reminder to all of us about the immense value of investing in public health preparedness. But it's also why the stumbles in getting these tools deployed were especially frustrating and inexcusable. To learn from this, we need to be clear-eyed about what went wrong, not just on the challenges we faced in the last several months, but that we have faced for decades. Challenges that, to be frank, have spanned many administrations, not just this one. For example, we had over 20 million vials of smallpox vaccine in our national stockpile, but they were not replaced as they expired over the course of a decade. I know I join my ranking member and members of this committee when I say we have got to do better, not just on COVID, not just on monkeypox, but on public health threats, period, because we know there will be more. Just last week, New York declared an emergency due to polio, yet another public health risk we need to watch closely. So I want to hear from our witnesses today about not just what they're doing right now to improve our response to the monkeypox outbreak and fast, but also how we can fix this in the long term and make sure the stumbles of the past couple months never happen again. I want to know what you and the administration are doing to make sure we have enough tests and treatments and vaccines for this outbreak and get them where they need to go, while also maintaining an adequate stock of supplies for any smallpox threats. What you are doing to improve outreach to the LGBTQ community, address disproportionate harm to Black and Latino communities, fight stigma and misinformation, and right the inequities we've seen in our response so far. How are we making the most of new research to develop promising vaccines and therapeutics and then make them more quickly available while continuing to uphold the gold standard of safety and effectiveness? And are we getting schools and colleges everything they need to stay open and keep students and schools communities safe? I'm glad CDC has provided guidance for K-12 schools, and fortunately the science tells us elementary and secondary school kids are not at high risk. And CDC has also released resources for colleges, which is critical with students returning to campus this fall. We need to make sure that colleges and universities are equipped to prevent potential outbreaks as students move into dorms and live in close quarters with each other. I realize you've got your work cut out for you in all of this, especially with COVID still raging, but there is no reason for us to fall behind. So I'm going to keep pushing you here because families back in Washington State and across the country are counting on all of you to get it right. That's also why I'm going to keep pushing my colleagues here in Congress about the need for funding to support all of this work. I know I'm not the only one here with concerns about the monkeypox response, but we can't just say this isn't working without providing the funding to end this outbreak and build the public health system Americans deserve. So I will continue to work with colleagues on both sides of the aisle and push to deliver the resources that will help get families the testing, treatments, and vaccines they need. And I'm interested in hearing from the witnesses on what the needs are when it comes to investing in our monkeypox response. It's also important to me we continue to keep our eyes on the horizon when it comes to future outbreaks and pandemics and build a stronger public health system for whatever threat comes next. As the saying goes, an ounce of prevention is worth a pound of cure, and that starts with building a world-class public health system rather than one that lags behind our peers. Our communities deserve to be as safe as anyone in the world, which is why Senator Burr and I are continuing to work to pass our Prevent Pandemics Act. Our bipartisan legislation implements the lessons from our COVID response and improves our policies and processes on issues like strengthening supply chains, improving management of our national stockpile, modernizing data systems, and other items which would address many of the challenges we faced with monkeypox. But a strong public health system also requires strong investments because our public health system was underfunded before COVID struck, and it has been overwhelmed ever since. We have to end the cycle of crisis and complacency by making sustained investments that allow us to build and maintain robust public health infrastructure at all levels. I will keep pushing for all of these steps because we should all know by now just how much is at stake. I can tell you that families in Seattle know, parents in Spokane know, nurses in Yakima know, workers in Olympia know, people across Washington State and across the country know. COVID was never going to be the last public health crisis we face, and neither is monkeypox. The question is not whether there will be a new threat, it is when it will strike and whether we will be ready. The truth is, the monkeypox response so far has not been encouraging, but there are some clear signs of progress, and there are clear steps that we can and should take to improve. And I don't want to just hear today about the steps you will be taking. I do want to see action, and I will be watching closely. I hope we can work together to build on the progress and end this crisis and make the kind of improvements we need to put our public health security on solid footing once and for all. Thank you very much, and I will turn it over to Senator Burr for his opening remarks.
Well, thank you, Madam Chairman. Good morning. I'm glad that we're finally here having a hearing on monkeypox outbreak, and it's as it hits our nation. While monkeypox is now a public health emergency, it didn't have to become one. I think the one promising thing that can be said this morning is the infection rate has slowed. That may be the only thing. Since May, when the first transmission was reported in the UK and Europe, I've been pressing the administration for a strategy and a plan. After almost 3 years of the COVID pandemic, you would think that the public health agencies responsible for our preparedness and response would be prepared for anything, particularly a threat like monkeypox, which we've known about for decades and for which we have vaccines and treatments. And Dr. Fauci's talked to this committee before about monkeypox. It's almost a definitional case of what CDC and ASPR and their sister agencies should be prepared to tackle. A virus that spreads through physical contact, a virus that spreads when an infected person has an obvious sign of infection. This is not like COVID, which was a newly emerged virus that spreads asymptomatic infection. But by any measure, in fact, by every measure, the response from the Biden administration on monkeypox crisis has been a catastrophic failure. You repeated each of the mistakes of the early days of the COVID response, and the cultural arrogance from public health officials who are supposed to be at the forefront of our response let this country down again. Since the COVID pandemic started, this committee's held 13 hearings on the response during both the Trump and the Biden administrations. I'd think you were sick of being called to the carpet and us having to hold you accountable for systematic failures. But it seems that nothing's changed. You can't blame the last administration on this failure. The first confirmed monkeypox case in 2022 was May 7th in the United Kingdom. The first case of monkeypox in this outbreak was reported in the U.S. on May 18th. We had warning. We had warning that this was coming. We should have been prepared to manage what came when it arrived. Let's review. We failed testing. Although you eventually made testing available through laboratory response networks, these tests were too hard to access. It took weeks before doctors were able to get their patients tested without having to first consult public health officials. There was also a significant delay in engaging the private sector on testing at the beginning of the outbreak. We waited until June 22nd to announce an engagement with the private sector. Still after that, companies interested in developing additional diagnostic tests that could help address some of the slow turnaround times and improve access have been left waiting months for samples needed to develop those tests. Without delay upon delay, you failed on vaccines. An enhanced strategy to offer vaccines to at-risk individuals known contacts was announced June 28th. But this was already after some local jurisdictions had already taken upon themselves to use the vaccine in this manner, and a full month after the UK Joint Committee on Vaccines and Immunizations met to discuss a similar strategy for their citizens. Why do we continue to be behind? Meanwhile, decisions about vaccine administration in the U.S. seem to have been made seemingly on the fly. Even when FDA issued an emergency youth authorization last month, allowing vaccines to be administered intradermal injections, there were no public meetings of FDA, CDC, outside experts to discuss relevant questions on the minds of impacted Americans and inform these decisions. Health professionals were confused about the initial decision, and patients were scared that they were being experimented on. To make matters worse, states had no time to prepare for this change in vaccine administration. Right after the FDA made its decision, ASPR reduced state vaccine allocations under the assumption that every vial would yield 5 doses. Yet, you know that this has not been the case in every state, resulting in some vaccinating fewer, not more, at-risk people. You failed at having a plan. Monkeypox outbreaks have been occurring in Nigeria and other places with increasing frequency. It was identified a threat under our threat matrix and a threat for which we had countermeasures in our stockpile. I might also add that our earliest purchase of the Bavarian Nordic vaccine in bulk was in 2017. But it seems there was no real plan on how to respond and what information and research we needed to understand this outbreak. Only after both I and the chair sent separate letters asking for a plan did the Office of Science Technology Policy blog about their research priorities. But the priorities were vague. It's not clear what research activities HHS has actually undertaken in response. These failures have allowed the disease to spread. 31 cases in May quickly turned into 650 cases in June, more than 6,000 cases in July, and more than 12,000 cases in August, and near 22,000 so far in September. It should have been obvious to all of us that the timing of these early cases, coupled with evidence that the cases were not linked, would create a perfect storm for a large outbreak. Monkeypox is a virus that largely transmits through skin-to-skin contact, most easily and frequently transmitted between sexual partners. Monkeypox arrived just before the Pride celebrations across the country, and after 2 years of lockdown and social distancing, your agency should have been screaming from the rooftops about what you knew or suspected about how monkeypox was spread. Instead, we remained silent. People got sick because of that silence. This isn't rocket science. But consenting adults need to be told what behavioral changes they should consider to avoid getting a preventable disease like monkeypox. You failed at a time when the communities most at risk needed you. Disease control and prevention and preparedness and response is literally in the name of 2 of your agencies. Yet you did none of that. It was no surprise to me that the administration, after months of floundering, appointed a new czar at the White House to coordinate the response. It shows why this committee passed the Prevent Act to create a mission control. The Secretary of HHS has been totally absent, and when he has been involved, it only seems it makes matters worse. But new ad hoc groups within government are exactly the problem. We need a consistent, coherent, government-wide response to be effective, and that can only be led by the White House. I hope that in the coming weeks we'll be able to get that legislation over the finish line, and I'll commit to spending my remaining weeks in the United States Senate doing everything I can to help the White House set up the new office with a lasting mission and clear agenda. If I were not retiring, I'd spend the next several years conducting a thorough examination of each of your agencies, highlighting each and every one of the systematic and bureaucratic failures that we've seen now and seen in response after response, and demand accountability for the American people. It isn't a question of authority. You have the authority. It isn't a question of money. You've been given astonishing amounts of money. It's a question of leadership. It's a question of focus. It's a question of squashing the typical bureaucratic roadblocks, arrogance, and ineptitude. You need to do better. We learned in Operation Warp Speed that when you press outside the box, when you focus on public-private partnerships, when you get bureaucracy tamed so that it serves the American people and doesn't try to control them, we can actually make government work. I'd ask you for your plan, but you don't have one. I'd ask you for what you'd change, but your agencies seem to think that they're doing everything right. I'd ask you who you're going to hold accountable, but failures at each of your agencies show that you don't believe in that type of accountability. So instead, I'll express my outrage and hope that eventually we'll get people in your agencies who will do the job to protect the American people instead of protecting their bureaucracies. Madam Chairman, before I close, I want to address a serious issue. The last time we were here, there was a coordinated assault pretending that somehow Republicans were at fault for there not being additional money for the pandemic. Let's revisit some of the facts if we can. The Senate, on a bipartisan basis, actually passed extra funding for COVID, $15.6 billion in March in the omnibus for testing, treatment, vaccines, and global aid. But the Speaker of the House either couldn't pass that legislation or didn't think pandemic money was a priority, so she stripped it out. I've worked with her for a long time, and I'm pretty sure she's a Democrat. Then Senators Romney and Blunt and myself engaged in deep negotiations with the Majority Leader and the Chair of the committee, and we reached a deal for $10 million in domestic funding for COVID. But the Majority Leader didn't want to take a vote against lifting a COVID restriction on the southern border, probably because he knew it would pass, so the deal was killed. I'm pretty sure Chuck is a Democrat. So then, at our last meeting, the chair and each of you got together and pretended that somehow Republicans were at fault. Republicans tried twice to provide additional funding for COVID, but Democrats couldn't take yes for an answer. Then last month, Democrats conducted a partisan spending exercise where Republicans weren't even in the room. They dramatically raised taxes by hundreds of billions of dollars, provided funding for 87,000 IRS agents to audit the middle class and spend hundreds of billions of dollars on Green New Deals that will mostly impact billionaires and millionaires. Those same Democrats who complain about no COVID spending didn't spend a dime of those new taxes on pandemic expenses. I often hear my colleagues say that your budget shows your priorities. But Democrats have the power to spend money on pandemic and chose not to. I guess making energy more expensive was more important. I think all of you know I've had in my jacket pocket a card with 4 simple requests from this administration and told them all they needed to do for me to get my Senate colleagues, my Republican colleagues, to support additional funding was to provide answers to those 4 things. Give us a detailed plan for COVID, detailed accounting of where the money's been spent, offsets to match new spending for pandemics, and a simple vote on a COVID restriction at the border. I first started that in April. Today, none of those 4 things have been presented. So, to date, the administration's failed to deliver. Maybe they don't want to actually have transparency on what they've spent, or maybe they don't want to come clean to the American people what their plan is until after the election. Not sure what it is. I'm tired of being the one that's blamed. I've got just as much invested as anybody on this committee in making sure that your agencies are successful for the American people. I'll continue to do that whether I'm in Congress or not. And Tony, I can't thank you enough for your years of service. It's been incredibly beneficial to the American people and to the health care of this country. I hate to see you go, but I also look forward to that day in January where we both are on the other side of this mountain, and I can actually not have to plan to fly on a Monday, and I can spend some time with wife and grandchildren. Having said that, Madam Chairman, let's have a reset this morning. Let's quit blaming everybody, and let's start showing some leadership. If the administration needs money, then send us a budget that requests money. There's no increased spending for COVID in next year's request. They believe that this is all going to happen by an emergency, that the American people shouldn't be held accountable. That's wrong. Get the administration to request the money. Let's work through the normal appropriations process. My hope is that there is a plan, and someday they will share it with us. I yield back.
Thank you, Senator Burr. I will now introduce today's witnesses. Dr. Rochelle Walensky is the Director of the Centers for Disease Control and Prevention and the Administrator of the Agency for Toxic Substances and Disease Registry. Dr. Anthony Fauci, the Director of the National Institute of Allergy and Infectious Diseases and the Chief Medical Advisor on President Biden's COVID-19 response team. Dr. Robert Califf is the Commissioner of the Food and Drug Administration. Don O'Connell is the Assistant Secretary for Preparedness and Response. Director Walensky, Director Fauci, Commissioner Califf, and Assistant Secretary O'Connell, thank you all for being here today. We all look forward to your testimony. And with that, we will begin with Dr. Walensky.
Chair Murray, Ranking Member Burr, and members of the committee, I appreciate the opportunity to discuss monkeypox and CDC's response to this global outbreak. To date, there have been over 59,000 cases of monkeypox reported globally, including over 22,000 cases and 1 confirmed death in the United States. In the current outbreak, the first cases were diagnosed in the United Kingdom on May 14th, and within days, additional countries began identifying case clusters. On May 17th, a case was reported in Massachusetts and was confirmed by CDC the following day. CDC immediately began its work, searching for additional cases, educating clinicians and the public about this disease, and supporting our state and local public health partners in their response. In less than 1 week, CDC reached out to commercial labs to increase testing capacity and began to scale up an incident response. Over the last several weeks, we've been pleased to see a decline in the growth of new cases here and abroad, though there are areas in the United States where the rate of rise in new cases is still increasing. We approach this news with cautious optimism, recognizing that we must continue to aggressively respond to with our entire toolkit, including vaccination, testing, and education about risk to inform behavior change. This outbreak has been notable for transmission primarily, but not exclusively, through sexual contact. It has disproportionately affected gay, bisexual, and other men who have sex with men, with a large majority of cases in this population. CDC has been studying monkeypox for decades and has contributed to the creation of the test, experimental therapeutics, and vaccines that are available today. But as a relatively rare disease, almost no providers in the U.S. have seen or even heard of monkeypox. Provider education has been a key component, indeed a remarkable challenge, but critical to our response. CDC has issued 4 health advisories, each reaching over 1 million people, and host clinician outreach calls joined by tens of thousands of clinicians. We've also shared monkeypox information for congregate living and K-12 schools to prevent monkeypox spread in these settings. Initially, our public health laboratory response network labs across the country were able to collectively test up to 6,000 clinical specimens each week using a diagnostic test developed to detect orthopox viruses, including monkeypox. CDC worked with our public health partners to quickly expand testing capacity and engage commercial laboratories to increase capacity to 80,000 tests per week. While weekly testing volume is currently 14% of total testing capacity, we are working with academic medical centers, commercial and public health laboratories to make testing even more accessible to all who need it. From the beginning of this response, CDC has worked closely with ASPR to make JYNNEOS vaccine available to based on their case numbers and underlying population at increased risk. Based on data from 39 jurisdictions reporting to CDC, a total of over 540,000 JYNNEOS vaccine doses have been administered. Collaboration with communities most affected by the outbreak, including the LGBTQ+ community, is critical to our response. We rely on our partners across public health and LGBTQ+ advocates and community-based organizations to contribute to their expertise to our response, to challenge us to continue to do better, and to amplify our public health messages. In recent weeks, CDC has provided technical assistance and support for vaccination efforts and other monkeypox response activities at large events serving LGBTQ+ audiences like Charlotte Pride and Atlanta Black Gay Pride weekend. These efforts and others have facilitated delivery of vaccines to those who may face unique barriers to access, including racial, ethnic, and geographically diverse populations. The robust response required for public health threats like monkeypox underscores the importance of sustained investments in the core capabilities that should constitute the foundation of a 21st century public health system. In addition, CDC needs additional policy levers to enable the timely reporting of data necessary to take the informed action the public expects of us. Despite having a vaccine distribution strategy since June 28th, it took until early September to complete all 61 data use agreements needed to receive vaccine administration data. While we work to control this outbreak in the United States, we anticipate that monkeypox will continue to be a global threat. Once this outbreak is controlled, we will need to maintain vigilance, education, and vaccination efforts so that another outbreak does not emerge. That is why now it's important for Congress to act upon the supplemental request. CDC will use the additional resources to support testing and laboratory capacity expansion, vaccination efforts, surveillance, epidemiologic investigations, outreach, education, and global efforts. Together, we can meet the fast-evolving threat of monkeypox, successfully end the current outbreak, and prepare for any future outbreaks. Thank you. I look forward to your questions.
Thank you. Dr. Fauci.
Madam Chair, Ranking Member Burr, members of the committee, thank you for giving me the opportunity to discuss with you the role of the National Institute of Allergy and Infectious Diseases in conducting and supporting research to address the ongoing monkeypox public health emergency. I will outline how long-standing NIAID-supported research efforts have enhanced our preparedness for, response to, the emergence of monkeypox virus. First, I want to provide some historical context that relates to past, current, and future NIAID research efforts. It is worth noting that the emerging epidemiological pattern of monkeypox cases bears a striking resemblance to the early cases of HIV/AIDS. In the United States and other non-endemic countries, monkeypox is disproportionately affecting men who have sex with men. However, anyone exposed to the circulating virus can get infected with monkeypox regardless of their age, gender identity, or sexual orientation. Thus, we would be wise to heed an observation I made 40 years ago in an article I published in the Annals of Internal Medicine in 1982 during the first year of the HIV/AIDS pandemic, when I referred to what we would soon call AIDS, a disease that did not even have a name at that time. And I quote from that publication, "Any assumption that it will remain restricted to a particular segment of our society is truly an assumption without a scientific basis," unquote. And so, although we must focus our efforts on the group that is most predominantly afflicted and at risk, there is still much we must learn about this disease. Additional epidemiological and observational cohort studies, surveys, ongoing surveillance for new cases are of critical importance. In addition, much work needs to be done in virology, immunology, transmission, and animal reservoirs, as well as diagnostics, therapeutics, and vaccine, which I will address in a moment. There are certainly some sharp differences between the early years of AIDS and our current situation with monkeypox. Unlike the situation at the start of the AIDS outbreak, the etiologic agent of monkeypox has been known for decades, and medical countermeasures have been developed, namely a vaccine, Jynneos, and an antiviral, tecovirimat, or TPOXX. This is the result of decades of NIAID-supported research on monkeypox virus and other orthopox viruses, including the variola virus that causes smallpox. NIAID-supported research was essential to the development of Jynneos vaccine. We funded a number of studies of Jynneos from the preclinical stage through phase 2 clinical trials to evaluate safety, immunogenicity, duration of protection, and route of administration. We then transitioned the vaccine to barter, which supported advanced clinical evaluation, and we have recently launched a clinical trial further evaluating alternative routes of administration. In the area of therapeutics, NIAID funded the discovery of tecovirimat and the preclinical studies to determine the mechanisms of action and its safety and efficacy in animals. Again, together with BARDA, we also funded phase 1 and phase 2 clinical trials of tecovirimat. Clinical trials to evaluate this drug in humans with monkeypox are needed to gather additional data about the safety and efficacy of the drug in the context of the current outbreak. NIAID-supported investigators have recently launched a phase 3 clinical trial of tecovirimat focused on outpatient setting in the United States through the AIDS Clinical Trials Group. A separate NIAID clinical study of tecovirimat in collaboration with researchers in the Democratic Republic of the Congo will begin imminently. It is worth noting that the study in the DRC was planned prior to the current global outbreak as part of our preparedness efforts to study high-consequence pathogens in key international locations where they are endemic. Lessons learned during the response to AIDS and COVID-19, such as avoiding stigma and ensuring the medical countermeasures get to where they are needed most, should help us in our efforts to respond to the ongoing monkeypox emergency. In addition, the U.S. response to monkeypox should in turn help to inform our response to the inevitable next emerging or re-emerging infectious disease of pandemic potential. Thank you for your attention. I would be happy to answer your questions following the presentation of my colleagues.
Thank you. Dr. Califf. You want to turn on your mic?
Oh, there we go. Chair Murray, Ranking Member Burr, members of the committee. Thanks for the opportunity to provide information on FDA's ongoing work related to the monkeypox virus public health emergency. FDA has been actively working with our government and private sector collaborators to respond to the continuing public health threat since the first monkeypox case came to the U.S. We've been working diligently to help ensure access and proper information regarding vaccines, diagnostics, and treatments for those who need them most. There's currently one FDA-licensed vaccine, Jynneos, available for the prevention of monkeypox. We originally approved this modified Vaccinia Ankara vaccine for the prevention of smallpox. Following reports of monkeypox in May, FDA recognized that production for this vaccine would need to be accelerated. FDA and BARDA worked together to expedite the submission of a manufacturing supplement that would allow more doses to be used in the United States. FDA approved that supplement in July, following an inspection of the manufacturing facility in Europe. In August, we granted an emergency use authorization for intradermal administration of the vaccine, which has helped to increase the supply of vaccine available to Americans up to 5-fold. The authorization allowed additional review of a 2015 clinical study that evaluated a 2-dose series of Jynneos given intradermally versus subcutaneously in individuals aged 18 years or older. Consistent with previous studies and extensive experience with a similar vaccine in Germany, data indicated that intradermal administration produced a similar immune response to subcutaneous administration with a modestly different reaction profile at the injection site. The combination of vaccination and preventive measures to reduce the risk of contact with the virus remains the best way to prevent the spread of monkeypox. The vaccine is available via intradermal administration for individuals 18 years of age and older, determined to be at high risk for monkeypox infection, and available via subcutaneous administration to those under the age of 18 determined to be at high risk for monkeypox infection. It's important to recognize that we do not have clinical data on safety and efficacy, so FDA continues to monitor safety data we're receiving following the administration of Jynneos nationwide. Additionally, as you've heard from Dr. Fauci, NIH has initiated a clinical trial to obtain further data. FDA has also worked closely with CDC, manufacturers, and laboratories to support diagnostic test development. Currently, CDC has an FDA-cleared test that can detect non-variola orthopox viruses, including monkeypox, by a swab from the lesion. This test is available through 67 CDC laboratory response network labs, as well as through 5 large commercial labs. On September 7th, following an emergency declaration from HHS, FDA issued an EUA for an additional test from a commercial developer. We also issued guidance on the development of diagnostic tests and hope it will increase the diversity and availability of tests for monkeypox. Currently, there are no FDA-approved treatments for monkeypox. TPOXX, or tecovirimat, is an FDA-approved treatment for smallpox, currently made available to monkeypox patients under a CDC expanded access investigational new drug protocol. TPOXX was originally approved for smallpox using FDA's animal rule. The animal rule is an approval pathway that relies on animal studies and can be used only when human trials are not ethical or feasible. Because monkeypox remains endemic in countries around the world, and we now have a large outbreak in the U.S., human clinical trials are both ethical and feasible in a way that they were not feasible for smallpox, as smallpox has been eradicated and has a 30 to 50% mortality rate. Without human trials, we don't know if TPOXX is beneficial for patients with monkeypox. Drugs that show efficacy in animals are not always effective in humans. Therefore, clinical trials, one of which is now underway, as Dr. Fauci has mentioned, through the NIH, will be necessary for FDA to determine if TPOXX is safe and effective to treat monkeypox. In the meantime, because there's a significant risk of the development of viral resistance to TPOXX, judicious use of TPOXX and careful monitoring for the development of resistance are of paramount importance for stewardship of this potentially beneficial drug while we study it in clinical trials. FDA's dedicated staff continue to work to ensure an appropriate and robust response to the monkeypox outbreak. Thanks for the opportunity to testify today, and I look forward to answering your questions.
Thank you. Assistant Secretary O'Connell.
Chair Murray, Ranking Member Burr, and distinguished members of the committee, it is an honor to testify before you today on ASPR's work in the ongoing monkeypox response. Let me start by sharing the work ASPR has done to procure and distribute vaccines. The Strategic National Stockpile stores vaccines that can be used in a smallpox outbreak. Among the vaccines it stores is a small stockpile of Jynneos, a relatively new vaccine for those that are immune compromised and unable to tolerate the live replicating virus in the other smallpox vaccines. And since Jynneos is also licensed for monkeypox, we have deployed these vaccines for the current response. When the first case of monkeypox in the U.S. was identified, the SNS had 2,400 vials of Jynneos in its on-hand inventory and immediately deployed vaccine to support the first cases. And when there were still only 2 known cases in the U.S., ASPR requested 36,000 Jynneos vaccine vials be shipped to the SNS from our U.S. government-owned reserve stored by Bavarian Nordic. When there were only 13 known cases, ASPR ordered an additional 36,000 vials from its reserve. And when there were only 35 known cases, ASPR ordered an additional 300,000 vials from its reserve. All of this was done to stay ahead of the virus. Though case counts were very low in the United States, we were watching the quick spread of cases in Europe, which was about 2 to 3 weeks ahead of us. And we moved out quickly, anticipating similar spread in the U.S. in the weeks to come. So far, ASPR has made over 1.1 million vials of Jynneos available to states and jurisdictions for use against the current outbreak. And we have purchased 5.5 million more to arrive over the next months. Bringing Jynneos manufacturing capability onshore has been another focus of mine at ASPR. This summer, when we purchased the second 2.5 million doses from BN to be filled and finished, our contract required that those doses be filled and finished in the U.S. And we have been pleased to support BN's arrangement with Graham to do that fill-finish in Michigan. We have provided Graham with $11 million to secure the equipment and staff it needs to ramp up quickly. I visited Graham 2 weeks ago as they are bringing on this new line and was pleased with the progress that I saw and to hear that they will be adding over 70 new jobs in Michigan to support this work. Vaccines are not the only medical countermeasure ASPR has made available in this outbreak. We have also made available the therapeutic TPOXX. Prior to the start of the outbreak, the SNS held more than 1.7 million courses of TPOXX. To date, over 37,000 courses have been distributed. I've been pleased to make both of these medical countermeasures available for the current monkeypox outbreak. It is the right thing to do. But I have not lost sight of the fact that both Jynneos and TPOXX were developed and stockpiled for use in a smallpox outbreak. I have consulted with the FEMC, the interagency body responsible for advising HHS on medical countermeasures development and procurement, and they have agreed with the approach we have taken. It is important, however, that as we move forward with our response, we consider ways to preserve our smallpox capability. We have also applied several lessons learned from the COVID-19 response to our work in monkeypox. As we digitized the SNS countermeasure ordering system, we opted to use a program that allows states to order both vaccines and therapeutics from the same system, rather than using separate non-interoperable systems for each, as they have had to do in the COVID-19 response. Using this multi-platform ordering system is a step towards modernizing our public health infrastructure for the current response and for future responses. We have also expanded the number of sites to which the SNS delivers. At the start of the outbreak, the SNS only delivered to 5 sites in each jurisdiction. This was more than enough for the high-consequence, large-scale events the SNS has been deploying to, such as hurricanes and tornadoes. However, after seeing the advantage of multiple distribution sites in the COVID-19 vaccine and therapeutics effort, the SNS contracted to create a similar distribution network for its countermeasures. These are just 2 of the examples of the lessons we have taken from the ongoing COVID-19 response and applied to the current monkeypox response. Responses cannot be static. They must continue to evolve and calibrate to the current set of circumstances and regularly account for new information and evolving scientific understanding. This has been true of the monkeypox response thus far and will be true as it continues. Thank you again for inviting me to testify before you on efforts within ASPR to support the ongoing monkeypox response. I look forward to answering your questions.
Thank you. Thank you very much to all of our witnesses for your testimony and for being here today. We will now begin a round of 5-minute questions of our witnesses, and I ask my colleagues to keep track of your time. As always, hopefully you can stay within those 5 minutes. I know each of your agencies have worked relentlessly to respond first to COVID and now monkeypox, but I have to say, frankly, too many missteps were made early on in the response, and a couple hundred cases turned into 21,000. It is unacceptable to communities who already experience barriers to accessing health care, like the LGBTQ+ and the Black and Latino communities that are hardest hit by this outbreak. Access to testing was an early challenge in the monkeypox response, with many people reporting significant delays in both accessing the tests and learning their results. To continue to have these challenges around testing is just simply unacceptable. So, Dr. Walensky, let me start with you. How is the CDC working to make sure tests are more accessible and results are available earlier?
Thank you, Senator, for that question. One of the big challenges that we had in terms of access to testing was both patients understanding that they were presenting with a new infection, and providers understanding that this was a new infection that they had to test for. Indeed, another important clinical consideration was that people were coming in requesting a test when they had no symptoms and they had no rash. As Dr. Califf noted, the test for this infection is a swab of the rash. So in fact, there is no other FDA-approved test. We need to have a rash in order to conduct those tests. So much of what we've done, and I should mention that we've always had more capacity than we have had tests coming in. To date, we've used about 14 to 20% of our capacity. But to address these access issues, we had to work with clinicians, we had to work with patients, we had to do an extraordinary amount of outreach so that providers would understand how to test, patients would understand when to come in for a test, and our public health partners would know not to gatekeep those tests. And so that was the work that we did early on as we were scaling up testing, knowing that we may need more testing coming forward. So through the Laboratory Response Network, we increased our capacity to test through expanding the manual extraction to automated extraction. Then we worked, as you heard, through our commercial labs to expand testing across the country, and simultaneously working with outreach and education to providers, clinicians, patients, and public health. Thank you.
Thank you, Dr. Califf. Secretary Becerra recently declared that FDA can use the emergency use authorization pathway for monkeypox tests. How will that improve the availability of new tests? And what steps are you taking to improve on the progress that you've made?
First of all, let me concur with Dr. Walensky. There's never been a shortage of tests, but there's been a shortage of access to tests because of inefficiencies in the system. So the EUA authority has enabled us. We've given one EUA already, but we also have 5 commercial labs which are offering the tests at this point. And we issued a guidance just the other day, which makes it clear that individual institutions that are developing laboratory-developed tests should proceed ahead. And we've given people clear guidance and templates for developing their tests and figuring out if they work. So I'd say on all fronts, the gates are open under a watchful eye, because we also must keep in mind that one of the lessons from COVID was that when the gates were open, a lot of tests that turned out not to be so good got out there, and we had to rein them back in.
Well, look, I'm encouraged by the decline in cases, but it really is imperative that we remain vigilant. And despite efforts by HHS to increase access to vaccines, some people in my home state of Washington still go to great lengths to get one, including crossing the border into Canada. Now, people understandably want to be vaccinated before they get exposed, but we need more vaccines. So, Ms. O'Connell, some serious stumbles were made this year when it came to our vaccine supply. What have you done to make sure that that never happens again? And what are you doing to increase the supply and distribution of vaccines right now?
Chair Murray, thank you so much for that question. What's most important to us is that those that need access to this vaccine get it. So if you continue to hear from constituents that are unable to access a vaccine or having to cross the border, please let us know. We are in the business right now of knocking down those hurdles and making sure the vaccine can be accessed. We did take a very small stockpile that was intended for smallpox, that was eventually intended to be lyophilized, freeze-dried for smallpox, and convert it to this active monkeypox response. And that required a couple of challenging problems to solve. We moved the first 372,000 vials, as I mentioned in my opening statement, immediately. We needed FDA to approve, and they were terrific partners moving quickly, to approve that second manufacturing line that began drew the 800,000 vials we were waiting for. That's what it manufactured on. We needed that approval to happen before we could deploy those. FDA worked quickly, and we got those out in July. We have also ordered an additional 5.5 million vials of the bulk drug substance that was intended to be lyophilized for smallpox. We have ordered that to be filled and finished and shipped to the United States, and 2.5 million of those will be manufactured in the United States. By adding a second line in Graham, one that's onshore, domestic manufacturing, we'll be able to access these vaccines much quicker in the future, and it's a critical step forward in our preparedness, both for this monkeypox response and for future smallpox programs.
Senator Burr.
Thank you, Chair. Tony? Last time you spoke on monkeypox here, you made it very clear that monkeypox is a result of animal to human transmission, and that happened abroad. Here's my question. If we allow monkeypox to circulate in our population indefinitely in the United States, what are the chances, and has it been studied, whether there could be a transmission from human to animal in the United States where we could have a threat that's animal to human transmission then that's domestic?
It's certainly possible, Senator Burr. Whenever you have a situation where you have an animal reservoir and the virus has already shown you from the standpoint of transmission that it can infect animal species, and you actually have an individual who is infected, there is no real reason why that not could go the other way. I don't believe that we have seen that, but I would not be surprised if we do see essentially going back and forth. That is possible.
And that would present a real problem.
Well, that would present a problem of the propagation. I mean, when you want to eliminate an infection, I mean, there's eradication, there's elimination, and there's control. The best way to eradicate or eliminate it is if you keep it out of the realm of an animal reservoir, which continues to refeed into the human population.
Great, thank you. Dawn, news outlets have recently reported the administration's evaluating whether some doses of Jynneos should be held back in the stockpile to meet are requirements for smallpox rather than distributed to support the current monkeypox response. This seems to conflict with FDA's recent decision to implement dose-sparing strategies, which indicates that we need to maximize the number of available doses. Can you square this up for me?
Thank you, Ranking Member, for that question. So we continue to maintain our smallpox preparedness. That's critical. Our frontline vaccines continue to be available and have not been impacted by our monkeypox response. But we have added the capability to be able to provide the Jynneos vaccine to those that are immunocompromised in the case of a smallpox outbreak. And we are evaluating with each dose that we make available to the monkeypox outbreak what it means for that preparedness in smallpox. I've met with the FEMC. I've consulted with them to understand whether we need a separate monkeypox stockpile so we can pull those vaccines off the shelf and not worry about the preparedness for the immunocompromised in a smallpox outbreak.
Have you ever thought about the message you send to the at-risk population when you suggest to them that though they're in the midst of an infection problem, that we're discussing holding back in case we have an outbreak of smallpox? Now, let me just explain. We know that we have 13 to 15 million gay men in this country, in the United States. Tony, we have about 1.9 million HIV/AIDS positive gay men. There's your immunocompromised population, 1.9 million. Your risk pool for sexually transmitted monkeypox, about 13 to 15 million. And somehow we're cheering the fact that we put out 700,000 vaccines. If I'm in that community, and then on top of that, we have the subdermal decision, I'm going to cut the amount that you get, and there's not sufficient public, transparent information about that, you've got a population that's a little bit questioning whether you're doing everything to help them. And that may be a reason that we've only had 461,000 people vaccinated out of a pool, a defined pool of up to 15 million people, of which 1.9 million are immunocompromised because they're HIV positive. Dr. Califf, currently the FDA, I'll switch gears for just real quick. Currently the FDA authorizes COVID-19 vaccines and antiviral treatments to be purchased only by the federal government, prohibiting anyone else that's not government from purchasing these vaccines. I believe we all agree on the crucial role vaccines and treatments play in stopping and reducing the spread of the virus. So why must every dose pass through the bureaucracy of Washington before it reaches a patient? And why are we still restricting access like that?
Thank you, Senator Burr. I think it is, by the way, I'm glad you're fully functional after your recent surgery, and you're definitely spry. You're showing good evidence of that. So let me just say that, you know, we have the vaccine. It's available. It's everywhere. You can just make your appointment and get it. And we expect that this will transition as there's been much discussion over the next period of time. But for right now, those are the rules under which we operate.
That's why plan is somewhat important. Mr. Chairman, just one last question for Dr. Fauci, if I can. Tony, the pediatric immunization schedule recommends 4 doses of polio vaccine before one reaches the age of 6 years old. With new cases of polio being detected in New York State, I'm wondering, do we know how long immunity for the vaccine lasts? To what extent is someone protected if they were completely polio vaccinated as a child?
It is not necessarily lifelong, but it is measured in decades and decades. So if a person has the full series of vaccinations, you could expect that they would be fully protected. The situation that we're concerned about are those who have either had no vaccination, like we saw with the case in Rockland County in New York, or individuals who have did not complete their full course. But if you have a full course, however, since it isn't necessarily lifelong, when a person goes into a zone where there's a lot of polio, you would recommend that they would get a boost. But I would prefer to perhaps that Dr. Walensky has something further to add to that.
I have nothing to add. That's
Right,
exactly
thank
where we are.
I thank the chair. Thank you.
Thank you, Senator Burr. I wanted to start by thanking the witnesses and obviously thank you for their public service. I'll start with Dr. Walensky. Part of the success of the COVID-19 vaccination campaign was the gradual shift from large vaccination sites to hyper-local sites where people could find vaccines in their own neighborhood, for example, like at a local pharmacy. We've seen the way in which convenient and local access to vaccines can help with uptake, whether we're talking about a vaccine for a new treatment like COVID-19, or a new threat, I should say, like COVID-19, or for routine vaccines like influenza and childhood vaccines. Obviously, people know and trust their own doctor and their providers, and they respond to community-based and community member-led efforts that meet them where they are. So, Doctor, how are you working with state and local partners to make sure we reach everyone who's at risk for infection, to make sure that they have the opportunity to get vaccinated if they so choose?
Thank you, Senator. A really important question in terms of outreach. So early on, as vaccines were being distributed, we were doing it in places where people were seeking care. Many of those places were in sexual health clinics or state-run clinics where people were receiving care. It is the case that not all members of this community have told their own clinicians about their sexual activity, and so it's very important that we do this in a sensitive and non-stigmatizing, affirming manner. So we were doing it in places initially where people were receiving care, but then many of the lessons, again, learned from COVID as we've rolled out these vaccines and delivered over 500,000 to members of these community, is that we need to do more and more outreach. We learned that we need trusted messengers, we need community-based organizations. I'm pleased to say that over the last several weeks, we've sponsored vaccine activities in several large-scale distribution sites like Atlanta Black Gay Pride, like Charlotte Pride, like Boise Pride, and like Southern Decadence. When we've done so, we've had really successful campaigns. So in Atlanta Gay Pride, we vaccinated over 4,200 people. Similar with Southern Decadence, around 3,000 people. What we need to do now is do those in smaller scale, and we're actively doing that scale up in smaller scale. So rather than these big events, we need to meet people where they are with community-based organizations, trusted messengers, exactly as you say. Thank you.
Thanks, Doctor. Next question would be for both you and Assistant Secretary O'Connell. We know that in the aftermath of the pandemic and now with the emergence of monkeypox as a public health threat, the need for ongoing dedicated investment in our nation's public health infrastructure, similar to what Chair Murray has called for in her Public Health Infrastructure Saves Lives Act. Our state and local health departments have been struggling for years after 2.5 years of the COVID-19 pandemic, and now with monkeypox in addition to that, they simply don't have the resources they need for routine public health work. So when an emergency comes up, they have to move funds around and sacrifice from their core programming, other programming like the ongoing opioid epidemic, lead screenings, anti-tobacco efforts, cancer screenings, routine vaccinations, on and on. So how would additional sustained funding for local public health infrastructure help us be better prepared for new threats like a new viral outbreak? Maybe I'll start with you, Assistant Secretary O'Connell.
Thank you so much, Chair, for this question. We continue to see states, jurisdictions, their public health departments worn out, tired, exhausted. We know they've been working for 2.5 years around the clock, and we've been relying on them to distribute vaccines and therapeutics, both in the COVID-19 outbreak as well as this new monkeypox outbreak. So one of the most critical investments we can make would be in additional staffing and not just throwing supplemental funds out that hire people but don't sustain them. It's important that we have multi-year funding that supports our public health departments. It's also critical that they can build these systems. I talked about the HPOP system that we put in place for the SNS digitized ordering, which is interoperable, that we're no longer having them trained on something called VTRAX that CDC sets up and then HPOP that HCOR sets up, but we have it on one system that talks to each other. They can order their vaccines and their therapeutics. By introducing that in this outbreak, we knew that the states were tired, and we worked very carefully with them on making sure they understood why we made this decision. And while it was hard, it does push us forward in a supportive way as we face this current outbreak and future ones. Dr. Walensky, I know that you might want to say more.
Thank you. If I could just briefly add, the core public health infrastructure is key. These need to be disease agnostic and long-term sustainable rather than crisis to complacency. And I'll just give you an example that our public health partners in the states and local jurisdictions do not have a line item for monkeypox resources. They have had to respond trying to be flexible with other resources that sometimes are not legally allowed. So as you know, the key core public health infrastructure of workforce, diverse as the communities they serve, laboratory infrastructure so we can scale up new labs swiftly, and then data infrastructure so we have interoperable data, just as the ASPR noted. Thank you.
Thanks very much. Senator Paul.
But she's had the flu for 14 days. Should she get a flu shot?
Well, no. If she got the flu for 14 days, she's as protected as anybody can be, because the best vaccination is to get infected yourself.
And
So
she should not get it?
if she really has the flu, she definitely doesn't need a flu vaccine. If she really has the flu,
She should not get it again.
no, she doesn't need it, because it's the most potent vaccination is getting infected yourself.
This is an ongoing question, and we've had ever-evolving opinions from you, Dr. Fauci. Currently, antibody surveys show that 80% of children, approximately 80% of children, have had COVID, and yet there are no guidelines coming from you or anybody in the government to take into account their naturally acquired immunity. You seemed quite certain of yourself in 2004, but in 2022, there's a lot less certainty. One of the things that we also know after looking at this for 2 to 3 years is that the mortality from COVID is very similar, if not less, than influenza. So when we look at this, we wonder, why you seem to really embrace basic immunology back in 2004 and why you seem to reject it now.
Well, I don't reject basic immunology, Senator, and I have never denied that there is importance of the protection following infection. However, as we have said many times, and as has been validated by the authorization by the FDA through their committee and the recommendation by the CDC through their committee, that a vaccination following infection gives an added extra boost. And that film that you showed is really taken out of context. I believe that was when someone called in who had had a reaction to a vaccine and asked me through a telephone in the interview if they should get vaccinated again. So it was in the context of someone who had a reaction. And as a matter of fact, Reuters fact check looked at that and said, Fauci's 2004 comments do not contradict his pandemic stance.
Actually, words don't lie. If you look at the words behind me, we can go over them a little bit at a time. She doesn't need it because the most potent vaccination is getting infected yourself.
It is true. It is true, Senator. It is a very potent way to protect.
So when you're trying to tell us that kids need a third or a fourth vaccine, are you including the variability or the variable of previous infection in the studies? No, you're not. Because when you have approved vaccines in recent times, and the committees that have approved it for children don't report anything on hospitalization or death or transmission. They only report that if you give them the jab, they'll make antibodies. And you can give kids hundreds of jabs and they'll make antibodies every time, but that does not prove efficacy. So what you're doing is denying the very fundamental premise of immunology that previous infection does provide some sort of immunity. It's not in any of your studies. Almost none of your studies from the CDC or from the government have the variable of whether or not you've been previously infected. So let's look at adults. I've had 3 infections. Should I get a 4th one? If you're going to measure whether I get a 4th one, you need a category that has a 4th one in it. and you need one that has nothing in it, no vaccine or the fourth vaccine. But you also need to know whether they've been infected. If you ignore whether they've been infected, you're ignoring a vaccine, basically, so you're ignoring a variable. So what you're giving us is this, you decry, and people decry vaccine hesitancy. It's coming from the gobbledygook that you give us. You're not paying attention to the science. The very basic science is that previous infection provides a level of immunity. If you ignore that in your studies, if you don't present that in your committees, you're not being truthful or honest with us.
Senator, if I might respond, I have never, ever denied fundamental immunology. In fact, I wrote the chapter in the textbook of medicine on fundamental immunology.
Any of the guidelines for vaccines,
You know,
do any of the guidelines for vaccines from the government include previous infection as something to base your decision-making on with vaccines? Do any of the guidelines involve previous infection? That's why you're ignoring previous infection, because it doesn't involve any of the guidelines. And furthermore, we've been asking you, and you refuse to answer, whether anybody on the vaccine committees gets royalties from the pharmaceutical companies. I asked you last time, and what was your response? We don't have to tell you.
Right.
We've demanded them through Freedom of Information Act, and what have you said? We're not going to tell you. But I tell you this, when we get in charge, we're going to change the rules, and you will have to divulge where you get your royalties from what companies, and if anybody in the committee has a conflict of interest, we're going to learn about it. I promise you that.
Mr. Chair, can I respond to that, please?
May.
Okay, there are two aspects for what you said. You keep saying you approve, you do this, you do that. The committees that give the approval are FDA through their advisory committee. The committees that recommend are CDC through their advisory committee. And you keep saying, I'm the one that's approving a vaccine based on certain data. So I don't really understand, with all due respect, Senator.
You're the one that said you would not reveal what companies gave you royalties or what company gave the other scientists royalties.
Got to move
That's
on.
what you told the committee.
Senator Paul,
Sir,
you got to move on.
Could I please answer that?
Briefly,
You
yes.
keep asking committees. They're not my committees. They're the VRPAC committee for the FDA and the ACIP for the CDC. So I don't have any idea what goes on
And they
with
won't reveal, as well as you won't reveal.
Okay,
what
we're
companies
gonna
you
move on. We're over time. Senator Paul, you're over. Everyone is over a little bit. I just want to make sure we keep on time here. For the record, I know Chair Murray and previous chairs of this committee of both parties have found videos to be out of order, and I will note for the record the video is out of order. We'll move to Senator Smith.
Thank you, Mr. Chair. Mr. Chair, I ask unanimous consent to submit a letter from AIDS United, the AIDS Institute, the National Alliance of State and Territorial AIDS Directors, the National Coalition of STD Directors, and the National Minority AIDS Council, outlining recommendations for a comprehensive approach to the monkeypox response. Mr. Chair, could I have unanimous consent for that, please?
Yes, so ordered.
Thank you very much. Thank you to our witnesses, and I want to add my gratitude to Dr. Fauci for your service to our country during some of our country's most challenging times. So thank you so much. I want to also start by associating myself with Senator Murray's remarks about the importance of Congress coming together to make sure the administration has the resources that it needs to respond to the monkeypox public health emergency. And I also agree on the need to sharpen our response and to work effectively with public health departments, including in Minnesota. Assistant Secretary O'Connell, we had a good discussion last week about distribution of the monkeypox vaccine, and I want to follow up on that. We talked about some of the challenges that the Minnesota Department of Health has experienced. The issue is that ASPR has opted to use the HPOP system, the Health Partner Order Portal, as I understand it, to distribute vaccines rather than the VTRAC system, which is how COVID vaccines were distributed and what the department is used to. As I understand it from ASPR's perspective, the HPOP system works better for distributing both monkeypox vaccines and treatments directly from the Strategic National Stockpile. There are also challenges with interoperability, as I understand it, with the VTRAC system. But of course, the issue, as we discussed, is that by using two different systems, one for COVID vaccines and one for monkeypox vaccines, this is a real challenge for the Minnesota Department of Health. And I suspect that this is a challenge for other agencies as well. Of course, this is happening at a time when these challenges are falling on public health departments and staff that are exhausted and burned out after the last 2.5 years of responding to COVID-19. And learning a new system in the midst of all of this is really a challenge. And it's sort of exacerbated, I think, by department having trouble tracking shipments of vaccines through VTRAX, and sometimes monkeypox doses just showing up unexpectedly. So could you just address for me, I appreciate you talked about this some in your written testimony, could you address what steps you are taking to work with state health departments that are in similar situations to Minnesota's to help improve how this distribution process is working?
Senator Smith, thank you, and thank you for the good conversation we had last week and an opportunity to talk about some of these challenges. So most important to us is that those that need vaccines can get them. So if anyone continues to find this to be a difficult system, please reach out and let me know. We want to knock down these hurdles to ensure that folks have access. We now have enough vaccine supply to meet demand, so it's important that people are able to access it. So we have a similar challenge that Dr. Walensky mentioned with the states. The states aren't able to use their COVID funding for the monkeypox response. We haven't been able to use our COVID funding for the monkeypox response either. So when it came to digitizing the SNS process, we were going to have to put new money into either the VTRAX system or the HPOP system. The HPOP system is currently being used in COVID-19 to order therapeutics. So states do have familiarity with HPOP. VTRAX was being used for the vaccines. Only HPOP could do both, and we were faced with putting annual budget funding into one of these systems in order to digitize the SNS ordering. And we chose to put it into the system that could actually do both. We believe that was an important step in moving forward, but we do acknowledge, Senator Smith, that our public health department colleagues are worn out and tired. We have had countless office hours with them to make sure they understand the system. If they're running into any problems, we're available to answer them. And as hard as this change management is, in the middle of two responses, it was the right thing to do to move forward to an interoperable system. We also have added additional distribution sites. That's one of the things we did with the SNS. We could not just piggyback on the COVID-19 distribution network. That was funded with COVID dollars. We had to go with the SNS, do an entirely new contract with a different distributor with annual funds and set that up. So that was one of the reasons why there was a delay. We've needed to overcome this and would look forward to working with Congress on making response dollars more fungible in the future.
I know that that would be helpful, and I appreciate your continuing to work the department. And obviously, getting the distribution right is everything when it comes to getting vaccines and making sure that people have access to vaccines. Mr. Chair, I'm out of time, but I will submit a question for the record about the importance of tribal consultation to our witnesses, and look forward to your response.
Thank you, Senator Smith. Senator Collins.
Thank you, Mr. Chairman. Secretary O'Connell, I want to follow up on the statement you just made. I don't recall any requests from the administration to use leftover COVID money for monkeypox. Moreover, it's not at all clear to me that you could not submit a reprogramming request to the Senate Appropriations and House Appropriations Committees for that purpose. So what exactly are you implying when you say that you haven't been able to transfer funds? You've taken funds for other purposes, including sending it to the border.
Senator Collins, thank you so much for your question and for the conversations we've had recently about issues. We've been advised by our legal counsel and by our appropriations team, our budget and finance team, that the money that's currently in the contract for McKesson, which is our distribution network that HCOR is managing, we could not piggyback on that same contract to set up a monkeypox distribution network. The way those funds work, we were restricted to supporting COVID response response efforts and not additional response efforts. But I'd be more than happy to meet with you and your team again and see if it's possible to do a reprogramming. But that was what we were advised, and so we took additional funds, different funds, non-COVID funds, and set up a different contract with AmerisourceBergen for the SNS to set up a distribution network.
Let me turn to another issue that we've discussed several times, and I do appreciate the fact that you have made yourself available. We have statements from Dr. Jha, from OMB back in March, that laments the decline of domestic manufacturing for COVID tests. And OMB in its March supplemental request talks about the volatility, which makes it difficult to preserve domestic manufacturing of tests. Dr. Jha says the United States government put a lot of efforts and resources into building up domestic manufacturing, and what we're seeing day by day, week by week, is that that's beginning to go away. I would suggest that it's the administration's contracting policies that have weakened our domestic manufacturing of COVID tests. As you and I have discussed before, the majority of the at-home tests the administration purchased for COVID were manufactured outside of the United States. For example, the administration awarded a Chinese company, iHealth, a $1.3 billion contract. That's roughly 4 times the size of the contract that was awarded to an American company, Abbott, which has a considerable presence in my state. So how is it that the administration is working with domestic testing manufacturing when you're at the same time awarding contracts to Chinese companies? That does not help to preserve domestic manufacturing.
Senator Collins, thank you. Domestic manufacturing of tests is a critical mission of ours in ASPR, making sure it's supported and an enduring part of the COVID-19 response when it moves from an acute response to a steady state. We will always want to know whether we've had COVID, whether someone we've interacted with had COVID. So testing is critical, and domestic manufacturing of tests are also critical. And regarding the iHealth contract, you'll recall when the president made the announcement that he was going to make 1 billion tests available through the U.S. Postal Service distribution system, the covidstest.gov. He also vowed at the time that he would not interrupt the commercial market, that he would not take tests that were currently going to the pharmacies and other stores. He would not take them out of the market and put them into the covidtest.gov program. In order not to disrupt that, the domestic manufacturers at the time were seeding the local pharmacies. We pulled in tests internationally so as not to interfere with what was available at the pharmacies. As soon as that leveled out, we made a commitment in the spring to only support domestic tests moving forward. But that initial decision was to not interrupt the domestic tests that were currently feeding the schools, the pharmacies, and the other pieces of the response. We wanted those to remain available.
Dr. Fauci, I just want to wish you well in your retirement. And a very quick question for you, and it's based on what you've written recently about the lessons of the AIDS pandemic. Though monkeypox cases are overwhelmingly related to sexual transmission and men who have sex with other men, should we be doing more to look at community spread and cases in the broader community, such as, for example, testing anyone with an atypical case of herpes or shingles, regardless of their sexual history?
Thank you for that question, Senator. The answer is yes, we are doing now serosurveys and surveillance that go beyond the well-established high level of infection in certain demographic groups. And that was part of the 5 pillars that I mentioned in my statement about virology, immunology, transmission, reservoirs, and serosurveillance. We're doing that in some of our studies, but the CDC is also doing that, and we're actually doing it in collaboration with them, using some of our cohorts in collaboration with the CDC's capability to do that. Perhaps you want to comment.
Yeah, maybe I will just add, thank you, Dr. Fauci, that among our health advisory networks that we've sent to clinicians and our outreach, for example, to the American Academy of Pediatrics, we make recommendations just like that, that say if there is an atypical rash, please consider monkeypox and test for it on your differential diagnosis. We make those recommendations. Thank you.
Thank you.
Thank you, Senator Collins. We'll turn next to Senator Baldwin.
Thank you, Mr. Chair. First, I'd like to ask unanimous consent to enter into the record an April 11th, 2022 article from Reuters entitled "Fact Check of Fauci's 2004 Comments Do Not Contradict His Pandemic Stance."
Without objection.
Thank you. I want to join my colleagues, Dr. Fauci, in wishing you very well in your retirement, and thank you so much for your service to this country. I'm going to start with you for a question on basic research. I think we're falling short when it comes to providing sustained investments in preparedness. That is why I led the Disease X Act to provide sustained funding for BARDA to focus on medical countermeasure development for viral families of concern. We can't just keep on responding to the threat in front of us. Dr. Fauci, can you explain how investments in smallpox research have made us better prepared for this outbreak than had we not made those investments?
Thank you very much for that very important question, because it relates not only to smallpox and the extrapolation of knowledge to monkeypox, but it relates to virtually all elements of fundamental basic research that ultimately, when you get to a problem that's a public health problem, it can be applied. As I mentioned in my written and in my oral statement, the original work that had been done on orthopox viruses dating back to 2001 and 2, following the anthrax attacks, when we put a lot of work into developing the countermeasures that Assistant Secretary O'Connell mentioned regarding smallpox, allowed us, by getting another type of a vaccine that is less reactogenic and has less adverse events, which led to Jynneos, which is now the primary vaccine for monkeypox. So the relationship between the smallpox research that had been done for decades on orthopox viruses and the acceleration of that research when we had the bioterror threat in 2001 and 2002 allowed us to respond rapidly with already developed countermeasures in the form of TPOXX and Jynneos.
Thank you. Dr. Walensky, for me, as we had a chance to speak earlier, monkeypox is all too reminiscent of our initial response to HIV/AIDS. I actually started my career in 1986 on the Dane County Board of Supervisors. In that year, the first cases of HIV/AIDS were reported in Wisconsin. There was a tremendous amount of fear and paranoia and sorrow in our community. We had to fight both the disease and the fear and the stigma and the discrimination that was present in the community. So, Dr. Walensky, can you describe CDC's efforts to work with the LGBTQ plus community to combat misinformation, to reduce stigma, and to ensure that folks have access to care?
Thank you, Senator, for that question. Their involvement and integration into our response has been critical. One of the first things that we did when we heard about the case on May 17th was outreach between our smallpox branch and our HIV branch, because we knew that it was both those communities, both those scientists that were going to need to come together to make a robust response. We've had extraordinary outreach with the LGBTQ community. We've met several times with the Human Rights Campaign, the LGBTQ serving FQHCs, Interpride and Pride organizers. We've facilitated best practice exchanges with tourism hubs. We have palm cards for Provincetown, Fire Island, Palm Springs, and then we've supported these large events like Black Gay Pride and Boise Pride, Charlotte Pride. Importantly, one of the things that we did early on, and this was one of the lessons learned from HIV decades ago, was that on May 27th, we first published an iteration of sexual health information on monkeypox for the LGBTQ community, so they would understand what practices would decrease their risk of monkeypox. All of this engaging a very robust, very active, and very helpful and informed LGBT community that have been essential in not only working with us, but in educating their own community. Thank you.
Thank you. I'll enter my last question into the record for Secretary O'Connell on what ASPR is doing to ensure this delay in vaccine availability is not a problem in the future, and anything you need from Congress to help address this. Thank you, Mr. Chairman.
Thank you, Senator Baldwin. I'll be turning the gavel over to Senator Baldwin, and our next senator is Senator Cassidy.
Thank you, Mr. Chair. So I was a medical resident in 1983 to 1986 during the HIV epidemic, when HIV just exploded. So I'm very aware of the need to have a robust research and public health response to infectious diseases. Now, Dr. Walensky, part of this has got to be predicated upon trust between the American people and the agencies, that the agencies are functioning as best as they can. And I feel like that trust has frankly been dissipated. And I'm sorry to say that, because I respect you as a clinician, as a person. But I've asked you on multiple occasions as to what percent of the CDC workforce is actually showing up. Frankly, you've always blocked that. You've never given a straight answer. So I'd like to enter for the record an article from the Epoch Times in which they did a FOIA request to find out how many folks at CDC were actually working, showing up, so to speak. And roughly 2,772 out of roughly 13,000 employees are showing up every day. But 78% are working completely remotely or come in maybe only twice every 2 months. Now, why is that important? First, that was a knowable fact, but it was not shared with Congress, we, the representatives of the American people. And I think the American people would like to know that if CDC is not functioning well, how many of the people are actually showing up. Now, I mentioned CDC is not functioning well because I now reference an article, which I'll enter for the record, from New York Times on August 17th, in which you, frankly, to your credit, point out CDC has not been working well, and that there is need for wholesale change. And at the end of the article, they quote an acting director under President Obama, Dr. Besser, who says that it's hard, first pointing out that you're still working remotely, you yourself are working remotely, at least of August 17th. And then he says, but it's hard to see how Dr. Walensky could execute wholesale changes when she only sees most of her staff at a distance. Quote, I don't know how you motivate and inspire culture change when people aren't together. Now, CDC is requesting billions of dollars for public health initiatives in an agency which, by your assessment, is not functioning well, in which only about 22% of the people are showing up every day, and in which previous Obama officials are doubtful that you can affect change because you don't show up every day. And I say that kind of painfully because I want the CDC to work. And yet, and one example, and I'm sure there's a reason for it, but there's been a lot of talk about the need for local agencies to have to modernize. But CDC was given $200 million under the CARES Act for data modernization to be awarded to 64 different state, territorial, local jurisdictions. And maybe this is HHS, maybe it's not CDC, but most of it has not yet been spent or allocated. This is according to CRS. So it's incredibly frustrating that a deliberate decision was made to not be transparent with the American people as regards the amount of people actually showing up for work. It takes a FOIA request from a newspaper, and now you're asking for billions more. Why should we trust?
Thank you, Senator, for that comment. I will say that we are an agency of 13,000 people. The people who need to be at CDC are at CDC, of course, our laboratory workers. We have many people in the field. We have people in 60 different countries.
Yes, but the article points out that there are many, that it's just wide open, that there's nobody showing up, that the offices are empty. So to suggest that all these people are field workers, I think, again, is another example of being opaque.
I don't imply that they're all field workers. I'm saying that many of them are field workers. Many of them are working at CDC and then deployed in responses, and many of them are on the road. I myself was in Atlanta last week for a day, but I was in New Mexico with tribal visits and doing a secretary's tribal advisory committee meeting. So many of us are on the road. I am here today, and I am working.
I'm sorry, what percent of CDC employees before the pandemic actually showed up for work every day as opposed to the only 22% now?
I don't have those numbers for you.
Yeah, I just feel like, and let me go back to, why should we trust CDC with billions when it's very difficult to get, I would say, a straight answer on what is the workforce in-person effort, and particularly when, by your own assessment, the agency is working so poorly?
The review that we did on August 17th was to demonstrate the lessons learned from the COVID-19 response. The people of the CDC are working well, they're working hard, and they don't necessarily need to be on-site in Atlanta. In fact, oftentimes they're more productive off-site in the field doing the work of public health.
So we're out of time, but let me just say that the former acting director of CDC from President Obama, when he said in the last paragraph of the New York Times article, he did not see how you were going to be able to, speaking of you in particular, affect change when you only see people every now and then. He was both suggesting that it was not a work completed, but it was something that had to happen now, and that when people not working together made that more difficult to execute. And I don't think anybody in here or anybody watching really thinks that only 22% of the CDC employees showed up for work at the building every day before the pandemic. They think it was probably 78%. And now the number's reversed. It's going to be hard for me to support more appropriations until we have a better relationship, a more trusting relationship, a more transparent relationship between the agency and Congress, which you're asking to fund your activities. With that, I yield.
Next, Senator Hickenlooper.
Great. Thank you, Madam Chair. And thank all of you for your service through, obviously, one of the great challenges this country has ever faced in its public health history, the pandemic, and then coming out of the pandemic, now we see other challenges. Let me talk a little bit about COVID-19 and the lessons learned, and we learned what to do and also what not to do. Again, we're back here with another public health emergency. I guess I'd ask you, Dr. Fauci, and I would want to echo also my gratitude and salutations for I know that you won't really retire because I don't think you're capable of not contributing to the public good, but I know you'll try. But the pathogen research at NIAID was critical to the development of orthopox vaccines and treatments, obviously a big help with monkeypox. But we may not have stockpiled vaccines for the next pandemic similar to COVID. And I'm just asking, in terms of the next public health emergency, how concerned are you that this next one, the next public health emergency, will be one that we don't have vaccines or therapeutics for?
Yeah. Thank you for that question, Senator. We always are concerned when you get a brand new infection that you've had no experience with, that you're not going to have countermeasures, particularly vaccines, that are ready in a timely fashion. So there are two approaches to that. We have described in detail in several publications and in some of our white papers what's called the prototype pandemic and prototype pathogen response. In other words, to look at multiple families, and there are about 7 or 8 high priority families. By families, we mean alpha viruses, arenoviruses, filoviruses, flaviviruses, and to do fundamental core research to, for example, to get commonalities among the pathogens within a family and to start to develop vaccines, put them in phase 1 and have them ready to go. With the new mRNA technologies, it's very simple to switch one epitope or one antigen in and out of the vaccine. That's the core of our approach right now, and I think you'll probably be hearing more about it because that's the thing that we're putting forth as the NIH's contribution to the government-wide pandemic preparedness is the prototype pathogen approach.
Right. Well, and I support that approach. I think that's the right direction to go and to make sure that we are as prepared as one can be for what is unknowable, and respect that, the challenges of that of preparation, but also the urgency. And we can agree and argue about, I think the government agencies across the board are going through the issues of how many people are going to work and how many people are working remotely. Every large corporation is dealing with this right now, and we're going to have to process through that. But in the meantime, we've got to make sure that we have the funding for pandemic preparedness because that is essential to the long-term future of this country in almost every way. Let me switch to this outbreak of monkeypox. When it broke out, we had almost 800,000 vials sitting at the manufacturer's facility in Denmark. But the shipment of these critically needed vaccines to the U.S. was held up pending. There was an FDA inspection of the facility, even though European regulators had approved it. So, Dr. Califf, I would ask you, how can we help the FDA better balance safety protocols with the urgency and the need to respond quickly to these emergencies?
Thanks, Senator. You know, the issue that occurred in this case was it was a new plant that BN had switched to. It had not been inspected by the FDA, and I probably don't need to remind you that we had more than one incidence in COVID times of a manufacturing facility not being up to par, which created a lot of difficulty and trouble. So we felt it was essential to get there, and in fact, we got there very quickly after the application came in from the company to do it and the outbreak occurred. But I think the balance here is the risk of a vaccine which is not up to par with the time it takes to make sure that the vaccine coming out actually will do the job that's intended. I'd also just add, Europe doesn't have a central inspections team for vaccine facilities. Each country does its own, and we have had some discordance historically between findings in some of those facilities and what we found in our inspection. So we really felt we had to get this right, even if it took a bit more time.
Okay, fair point. Great. I yield back to the chair.
Senator Marshall. Thank you, Mr. Chair. To my panel, as I read your testimony, listen to your testimony, what you described to me is an academic response to a problem, as opposed to being proactive, we're being reactive. And I would challenge you all to change your culture so that we're more proactive, a more of a military response to a problem like this. When I look back through the history of this virus, July 2021, there was a case in Texas from Nigeria. November 2021, a case in Maryland from Nigeria. In May of 2022, there's cases in multiple countries, all linked to Nigeria. And there was a moment in time before the horse was out of the barn that we could have stopped this. And now I fear that this virus is being transmitted from human to animal. And once it's in the animal kingdom, we'll never be able to get ahead of this. So my question for Secretary O'Connell is, did you ever consider a travel ban or requiring vaccinations from people that have traveled from Africa before they get back in this country? And then you made a statement on June the 3rd of 2022 that you said, I want to say we have enough on hand to manage this current outbreak. Do you still think that was the case then? And if so, why is it still exploding?
Thank you, Senator Marshall. I'd like to take the second one first and then invite Dr. Walensky, who has...
Well, we don't have that much time, but go ahead.
Okay. At the time that I made that statement, we were using the ring vaccination strategy, which is a strategy that has been effective in monkeypox outbreaks, including the ones that you just mentioned previously. It requires vaccine being administered to the person that has a virus and their close contacts. As the spread of the current outbreak began to indicate that anonymized partners would make it difficult for contact tracing to happen, we pivoted to those that were likely to be exposed, and we expanded.
So there was plenty of vaccines, and the problem was the execution, getting the vaccines to where they were needed?
The strategy that we were using to vaccinate the at-risk population changed as we were seeing the transmission change.
Okay, Dr. Walensky, just briefly, yes or no, did you all consider some type of a travel ban or requiring people to have a vaccine before they came to this country?
Maybe if I could just clarify, the two cases in 2021, one in Texas, one in Maryland, we were aware of. There were no contacts that ultimately had monkeypox. Those were isolated cases and unrelated.
But we traveled to Nigeria, from Nigeria.
Yes, and we have known that monkeypox is endemic in Nigeria as well as DRC, and intermittently over years, including 2 last year, we have intermittent travel cases that have led to no further cases. That happened in 2021. This is a different outbreak. This is May 17th was our first case. When we had our first case, I spoke to the clinician who made the diagnosis. We called Public Health Canada as that patient had traveled from Canada, and we immediately started outreach with our colleagues in the UK as well.
So I think it's a no, but there was multiple cases across Europe already, with most of them connected to Nigeria. I want to turn to fentanyl poisoning just a second, Dr. Walensky. Probably one or two people have died with monkeypox in the United States that I'm aware of, but every day hundreds of Americans die from fentanyl poisoning. Why have you not declared this a public health emergency? Why have you not asked the administration to shut down the border where 90% of this fentanyl comes from?
The declaration of a public health emergency is under the secretary, so I would have to defer that comment. I will say that...
But you could recommend to him that that would be done.
And we have those conversations. But what I will say is that our ability to shut down the border at the CDC level is related to communicable diseases. And while the fentanyl challenges...
Turning your back on the fentanyl poisoning.
Not at all.
More people have died from fentanyl poisoning. More Americans have died from fentanyl poisoning than we lost in Vietnam. This is what's killing Americans every day is fentanyl. Do you not have a heart for these people, for these moms and dads that have lost these kids?
And in fact, through my career, I've cared for many of them. And it is tragic. And we are doing a lot at CDC.
What are we doing?
But we do not at CDC have the authority to shut down the border on anything except a communicable disease.
So what are we doing?
We're doing outreach. We're doing mental health. We're doing community violence. We're doing surveillance. We're doing
But tons of fentanyl continue across the border. Really quickly, in 2017, there had been no cases in Nigeria for 40 years. Suddenly there was an outbreak, I guess 218 cases. Since then, the CDC, EcoHealth, UC Davis, funded by USAID, were all doing research in Nigeria at the time. I think it's for Dr. Walensky as well as Dr. Fauci. Were you aware of this research? What was the purpose of the research? Was it just collecting, or were we doing more than collecting? Were we concerned about lab outbreaks? And I've got a list of questions related to that research. But Dr. Fauci, were you aware of that research in 2017?
No, I'm not, but I could get that information to you. I'll have to check with the staff. I was not aware of it myself personally.
Dr. Walensky, were you aware of this?
We've been conducting monkeypox research in Nigeria for years, and I'd be happy to get you the details.
You know what the purpose of that research is?
I'd be happy to get you the details.
No, as I mentioned in my remarks, we are will be imminently conducting a clinical trial of TPOXX, in the Democratic Republic of the Congo. That's not fundamental basic research. That's a clinical trial in the Democratic Republic of the Congo.
Okay, thank you. We look forward to your answers. I yield back.
Senator Hassan.
I want to thank the chair and ranking member for this hearing and all their work. Ms. O'Connell, I want to start with a question for you to really just give you an opportunity to build on earlier testimony. The Department of Health and Human Services has been responding to COVID-19 now for over 2 years. You addressed this to some extent in your testimony, but could you just explain further how the department's experience with COVID-19 is informing its monkeypox response?
Thank you so much, Senator, for that opportunity. So we are continuing to actively respond to COVID-19. But are continuing to pick up lessons as we go. One of the critical lessons is making sure that we have systems when countermeasures are ordered, where states can order both the therapies and the vaccines on a same interoperable system. We've done that now as we've digitized the SNS's ordering process. It was also important that the SNS have multiple distribution sites across jurisdictions and states. Jurisdictions and states got used to that in our COVID-19 response. And the SNS up until this point has really only been able to do 5 distribution points in any state, consistent with the large-scale, high-consequence incidents it has been responding to, like hurricanes, tornadoes. But now that we move to this national vaccine strategy where we're trying to get vaccine out quickly to the high-risk populations, having those additional distribution sites is critical. And the SNS has entered into a contract now with Amerisourcebergen, which will allow it to distribute to multiple places. 500 ambient, 500 frozen distributions a day for 5 days a week, so up to 5,000 distribution points. Another thing that we've done is we've created a framework to ensure that the vaccines aren't going to the wrong place. One of the things we saw when we seeded the country in COVID and made sure we were giving it out on a pro rata basis, that sometimes it would end up in the wrong place and was not being administered. So we've asked states to self-attest to 85% usage. Is it going to the right places? That's not been a barrier. We're continuing to work with states to ensure that their second courses don't count against their 85% and that those that are in the field don't count against their 85%. But it's been a good framework for us to make sure shots are getting in arms, most important thing right now, and not sitting on shelves.
Thank you very much. I'm going to switch to a different topic with Dr. Califf, and I want to build Dr. Califf on conversations we've had before to discuss another public health emergency, which is the opioid crisis. During your confirmation hearing, we discussed how the FDA helped fuel this crisis by approving and labeling opioids for long-term use, despite a lack of strong evidence supporting those labels. I was encouraged when you told this committee that under your leadership, the FDA would aggressively look at relabeling. But in the 6 months since your confirmation, the FDA has yet to change any labels. The opioid epidemic continues to ravage communities in New Hampshire and all across the country, as we have all acknowledged this morning, and your agency needs to move swiftly to correct its previous mistakes. You yourself have repeatedly said that the FDA needs high-quality evidence to support the long-term use of opioids. The agency has the authority to remove labels from drugs now, given the absence of this evidence. So why is the process taking so long?
I want to express appreciation for your question and to mirror what's already been said here today. We're currently losing more people from opioids than we are from COVID. So this is a national issue that we need to all take seriously. I've taken the first 6 months to get an assay of everything that's going on inside the FDA and the all-of-government response, and also in the face of, the fentanyl mail order issues that are going on with high-dose fentanyl. None of that obviates the need to get back to the basics of the prescription of opioids. We published our framework last week. You will see changes over the next few months within the context of that framework.
So are you telling me that you are considering, or the framework calls for labeling opioids?
It's under active consideration and discussion within the FDA, yes.
Okay, because look, I just was at a recovery rally in my state with people who have engaged in peer-to-peer recovery, people who are helping pregnant women with their recovery, parents who have lost 2 children to fentanyl and to opioids. The FDA first approved and labeled opioids for long-term use more than 25 years ago. That means that they've been on the market for more than 25 years without substantial evidence that they are effective for that purpose, and with plenty of evidence about the harm that these drugs can cause. So I appreciate that there's a framework out there, but what people are looking for right now is action. I'll continue working with my colleagues on both sides of the aisle to ensure that it happens. And again, I thank you for your service and your attention to this.
I appreciate that.
Senator Rosen.
Thank you,
Chair Murphy, and for holding this important hearing. Thank you for everyone being here, doing all that you do in these trying times. That's for sure. I want to talk a little bit, though, however, about clinical guidance for all our practitioners, of course, their support staff, to prevent and treat monkeypox, because I would say many clinicians, maybe a majority of clinicians, have not directly treated monkeypox and may have not seen a wide range of cases, so it's critical for clear guidance to be widely available to all medical professionals, and I would also say their support staff who do answer the phones, take the questions in the room when they're doing their own histories and physicals. It's important for treatment and prevention. And so regarding monkeypox prevention, I have concerns about not just the slow rollout of vaccines to vulnerable populations, and I appreciate that you have been doing significant work to make the vaccines more available, but with all these vaccines rolling out, there's a new COVID vaccine, it's a flu vaccine, there's a pneumonia, there's a shingles, of course, then there's other things that people might get, tetanus, this or that, for adults. I'm talking about adult population. It's a lot of confusion about boosters. Can I combine vaccines? And so I'm really, really concerned that the CDC, Dr. Walensky, what are you doing to mount this public information campaign on the wide variety of vaccines, important ones, available? We don't want someone to maybe not get a shingles. My parents both had it. It's very painful. How are we going to do that? At pharmacies and public spaces, even besides our doctors, people may not be going to a doctor or clinic, but maybe they're going into their local drugstore or grocery store every week, right?
Yeah, so thank you, Senator, for that important question. And I think one of the things you raise is one of the challenges that we've seen, first with COVID, now with monkeypox, and one of the places I would really welcome Congress's help. We don't have a mechanism in this country by which we inform all clinicians of a new outbreak or a new disease. So this has been through a lot of public education. We've had a massive amount of outreach. We have health advisory networks that we reach out to. When we put out a health advisory, and we've done 4 for monkeypox, they reach about 1 million clinicians. We've done what we call clinician outreach webinars and calls, COCA calls. They reach about 6,000 clinicians. We put them online. They reach about another 10,000 each one that we do. We've done several of those. I personally have sent a letter to all boarded clinicians through the AAMC, working with each state to try and send letters out to inform people of a disease that they may have never heard of and may have never seen, but tomorrow might walk into their clinic. So what do they need to know? What are the protections that they need to take? And how would they diagnose, treat, and care for a patient with this infection? So that has been a lot of the work that we've had to do during this outbreak. I will say from a health worker safety standpoint, at least as far as monkeypox is concerned, we've seen very little outbreak in healthcare workers. We have had 1 diagnosed healthcare worker after a needle stick injury, but we have seen very little healthcare worker outbreak due to our personal protective equipment and the outreach that we've done in telling healthcare workers how to protect themselves.
But what about the broader idea of that we have this fall so many vaccines that are available, we'll just say to the adult population, preventative vaccines that we normally have, flu, shingles, pneumonia for a few of those, now a COVID booster, now potentially a monkeypox shot. How are you going to just get this out to patients, consumers, people in general?
So we do a lot of provider calls for that as well, our advisory committee on immunization.
What if you're not going to provider? How are you going to get it to the average person?
Well, so we've been doing we've been doing press conferences, we've been doing advisories. As we've rolled out both the bivalent booster, we have a massive flu campaign that we roll out in early October, which we will again do this year. One important thing I want to just highlight, though, is that we at CDC and we in this country do not have a mechanism like we do with children. You listed adult vaccines. I believe there are 13 of them that are advised. Adult vaccines, we do not have a mechanism in this country to finance adult vaccines the way we do vaccines for children's program. So when we look at the equity of getting vaccines to rural populations, to other populations, we do not have a mechanism by which to do that in an equitable fashion the way we do for children. That is a big constraint that we have right now.
Thank you. I know I only have 20 seconds left, but Dr. Fauci, I just want to ask you quickly, We have monkeypox, so medication to treat the infection, but there's symptom management. We hear a lot of talk about opioids. I know it's very painful, monkeypox. I don't know what the treatment might be, but what kind of guidance are you giving the medical community about effective pain management as it relates to the neuropathy, I would imagine, that monkeypox causes?
There are medications for the neuropathy, but importantly, particularly when it's on the mucosal surface, be it the anal, rectal, mucosal, or the urethral mucosal, that can be extraordinarily painful. We recommend, and the hospitals do this anyway, I think that's pretty common knowledge, it is an acute, not a chronic pain. So it's the kind of thing that you would not hold back on any type of pain medication just because you're concerned about addiction. The discussion that we've been having about fentanyl and the opioids is not using it for chronic pain. This is not chronic pain. This is very acute pain that usually resolves itself within a period of a couple of weeks, but you certainly don't want your patient to suffer inordinately by holding back pain medications.
Similar to that pain of shingles in that same way. Thank you. My time's expired. Thank you very much.
Thanks, Senator Rosen. I'll recognize myself for questions. I have two, one for you, Dr. Walensky, and one for Dr. Fauci. Dr. Walensky, one of the things I panic about is your access to data. And you've talked to this committee about it. We've talked personally about it. But outside of emergency authorities, you're stuck in a position today in which you have to negotiate 50 different data sharing agreements with states all over the country. And we expect a lot of the CDC, but it's hard to expect too much of the CDC when you don't have the authorities, as I understand it, to get the data you need absent an emergency. And when we look at what's happening today with monkeypox, you're getting data, but it's patchy. For instance, you're not getting full demographic data. So there's a lot of states that aren't reporting to you, for instance, breakdowns of cases on race or ethnicity. And that really hurts our ability to target who gets the vaccine, right? Who gets resources. So certainly in the context of monkeypox, but maybe more broadly, what position does it leave you in when you don't have the authorities to be able to compel states in a uniform way to get you good data?
Thank you, Senator, and thank you for the question and for your leadership in working with Senator Kaine, Senator Baldwin, in trying to get us the authority so that we can provide these data to you. We have been working closely, tirelessly, with state and local public health staff who have been doing the same to extract data on this outbreak specifically. We've actually negotiated now 61 data use agreements. We've navigated bureaucratic approvals for data to get flowing. We've set up voluntary arrangements directly with large commercial labs to send their data, but it's been hard, and it should not be this hard. And if we can't make informed decisions based on the best possible data coming into us, we're not making the best decisions for the American people. The existing patchwork of data systems is not working. It's not working to the best ability of the American people. For monkeypox specifically, I can tell you that I don't know the total number of people hospitalized with monkeypox, the data on laboratory testing in the United States, complete demographic data, as you noted, which people with monkeypox have been vaccinated. We can't link the monkeypox vaccine data to the laboratory data and demographic data, as you noted. We get 27% of our demographic data on testing. We've received 47% of our demographic data on cases, and 91% of our demographic data because of these data use agreements on vaccination.
I would just much rather have you be in the business of fighting the public threats presented to the country than in constant negotiation over data sharing agreements. It just seems like an essential function of the federal government to set up a uniform way in which you get data rather than putting you in the position of negotiating over and over and over again these data use agreements. And my hope is that soon we'll be able to find a consensus on that here. Scary that you don't know how many people are hospitalized for the monkeypox today because of your inability to get that data. Dr. Fauci, in the minute and a half remaining, I just want to talk a little bit about what we learned, what you learned over the course of the information distribution campaign for the COVID vaccine and how that relates to what we are communicating about Jynneos, because there's been some some amount of information regarding questions about the level of protection, the duration of the immunity when it comes to the monkeypox vaccine. And I don't know that this was necessarily your fault, but in the euphoria of the sort of early news of the COVID vaccine, we probably got out a little bit ahead of ourselves in terms of what level of protection it could provide. So what did we learn about how to talk about a vaccine in its early distribution stages, and how does that inform how we should talk about the monkeypox vaccine?
Well, first of all, there are two entirely different pathogens, and the response and the durability of response to each is really quite different. It was a rather unique situation with COVID vaccine where there was no doubt that the initial protection against symptomatic disease as well as severe disease was well into the 90s. That was the really good news. The sobering news was the durability of protection, particularly against infection and symptomatic disease. Fortunately, the durability against severe disease lasted. But if you look at coronaviruses in general, which is usually a good parameter of what the response to a vaccine is, even with a coronavirus infection, the durability of protection against reinfection long before COVID came along, just the typical common coronaviruses, did not last very long. And we see instances of reinfection with the same coronavirus. That poses a very different situation, which leads to the need for and the importance of updating vaccines and giving the boosters that are part of the regimen in addition to the primary regimen. When you're dealing with a pox virus, inherently, pox viruses have a much greater durability of protection. We know that because smallpox itself, once you get infected, you are essentially protected for life against reinfection. Once you get vaccinated with the standard smallpox vaccination, you can be sure that the durability is measured at least in decades and maybe lifetime. What we're dealing with now with Jynneos is that it likely is going to have a durability of protection if you get the 2 doses, not just 1. We want to make sure people get their 2 doses. The durability very likely is going to be much greater than that shortened durability of the COVID, because they are really fundamentally 2 different viruses.
Thank you very much, Dr. Fauci. Senator Braun.
Thank you, Mr. Chairman. I have 2 questions. First for Dr. Walensky and then for Dr. Fauci. Over the last 2 decades, HHS has issued only 4 public health emergency declarations: H1N1, Zika, Opioid Crisis, and COVID-19. On August 2nd, declared monkeypox a nationwide public health emergency. Of the over 20,000 people diagnosed with monkeypox, since May of 2022, there's been 1 fatality. I'm concerned that the public health emergency declarations will not be taken seriously if it's a litany for every new challenge that comes along to where we're going to get the public to buy into it. I guess I'd like to ask, what are the criteria used for determining whether a disease or a disorder constitutes a public health emergency?
Thank you for that question, Senator. What we were seeing in late May, early June was a doubling time of this, of new cases of about every 8 days, so increased number of new cases. And among the things that is important, I think, is we understand when a public health emergency, and in fact, I will invite the Secretary, Assistant Secretary O'Connell to maybe chime in here as well, is what are the things that that public health emergency unlocks for us to be able to do, whether it be inflexibility of funding and resources, whether it be in emergency use authorizations, whether it be in other flexibilities, so that we have the capacity as an agency to deliver as much health as possible. I don't know if Dr. Califf or Secretary O'Connell want to chime in there.
Just to concur with what Dr. Walensky said, the public health emergency created an atmosphere in which FDA was willing to use its emergency use authorization authority, in which it was easier for states to give us the data that Senator Murphy and Dr. Walensky just talked about. It makes it easier for local public health departments to shuffle employees around in order to put them towards the current response. So it created some flexibilities. It was also an important signal to the community that we were paying attention, that this is an emergency in our view, and that we want to provide as much countermeasures and response mechanisms as possible. It also aligned with what WHO did. It declared a public health emergency of international concern. We have the most cases in the world, so it was consistent with what their determination was. Ultimately, it's the Secretary's decision, and he made that decision in August, as you said.
Senator Braun, I would just chime in quickly. I agree on all the things that were unlocked. If the point is we need to keep looking at our emergency capacity and our planning for it, I think we all agree we need to keep looking at this as a continuum, because with climate change and everything else, there are going to be a lot more of these that come along.
And I basically agree with that conscientiousness, that kind of a being ready for it. But you do have to keep in mind that if it does enter some type of sequence where it gets dismissed because it's being declared too often, to me it looks like you'd want to, develop some criteria that, I know it's difficult to get everything into a subset, but I worry about how people will view it if it's a litany of public health crises, when we went through the COVID-19 journey, learned so much about it along the way. And of course, it was the last time, I think, Dr. Fauci, you and I spoke, we were talking about shutting down the economy, and you said that, we did that out of uncertainty. We probably never would want to do that again, and that cost trillions and trillions of dollars along the way. So we surely have learned a lot with that experience that we might use on others. Dr. Fauci, a lot of Americans are worried about the power of social media, and it was back over a year ago, in July, that we talked about, had there been any contact, with your office. And I know that here recently, a federal judge in Louisiana ruled that the Biden administration, including yourself, must turn over external communications with social media companies. So we'll see what happens there. You said there had not been any contact up to that point. Had any social media company contacted you since July when we spoke last? I know that's been a decent amount of time, so I was just curious.
I don't believe that I said there was no contact. I have had over a period of time, and I'd have to check the dates, Senator. Yes. Honestly, I'd have to get the correct dates, that Mark Zuckerberg of Facebook had contacted me to make some Facebook Live discussions about encouraging people to get vaccinated and how we can make sure that people understand the importance of vaccination. So there has been, and that's public record. I think anybody who has access to the public face of that Facebook would see, I think it were 3 conversations that I had back and forth with him about promoting the use of vaccinations as a public health intervention.
And I think on that particular public health advice about the benefits of a vaccine, it's probably not where that contention arises. I want to narrow in on this, and it would be the original discussion of where it came from, the leak, and then they used, from a lab or, from a wet market. And was there ever discussion on that? And to me, that's a different kind of issue
To my knowledge, there was not. I mean, I want to make sure I get correct your question. If the question is, do we influencing social media in any way, the answer is a categorically no at that. And any communications that are made in that regard, as far as I'm concerned, are an open book and available. The lawsuit that you mentioned, I think it's Missouri and Louisiana versus Biden and HHS and CDC and FDA and the entire government, because it involves the president, is under the Department of Justice right now. And I have handed, and my staff have handed over every document that the Department of Justice has asked for, and it's up to them to make it available. But I have held nothing back from anything that I was asked to provide.
Thank you.
Senator Brown, we got a vote pending, so I want to turn it over to Senator Burr. Thank you, Senator Burr.
Thank you, Mr. Chairman. Let me conclude, if I can. I want to thank all of you, and more importantly, thank your workforces for the work they've done over the last 3 years. Tony, I wish you well in the transition. I want to state this, and I want to be perfectly clear. We don't act or react fast enough. Let me say it again. We don't act or react fast enough. And we've been focused on monkeypox. Let me just do a recap real quick. May 17th, infection in the United States. 2 weeks prior, 10 days prior, 11 days prior, we see this in the UK. We already owned on big bulk storage of vaccines sitting at BN in Denmark. BN apparently speeds up their fill-finish line that wasn't supposed to go online until sometime in the fall. They apply. FDA on June 30 inspects. It's July 27th before the approval is made. Here's the concerning part. It's April 18th when we sign a deal for domestic fill finish somewhere else. Let me say that again. We start with May. We know we've got domestic infection. We're concerned with our ability to deal with this. And there's a big period that we don't look for domestic fill finish. I'm not asking for a response. I'm just making a point that if we have a pandemic response plan, things like this get resolved. And I don't know what the limitations have been placed on any of you about sharing the specific plan, whether it was on COVID or whether it was on monkeypox, and I don't really care today. What I do care about is that if you are in the role of leadership in your agency, or if somebody else is in the role of leadership in the future, the first thing they ought to be saying is, let's sit down as a group and let's put together a plan. Let's know what everybody's going to do. This BS of working independently, the turf wars that exist, we own testing, we own this, we own that. The hell with it. These are not, when you declare a national emergency, this is no time to protect territory or turf. And every response to us is about money. Dawn, if you need something changed or reprogrammed, for God's sakes, ask us. Don't use it as an excuse as to why you couldn't do something. Rochelle, we've reached out many times, and the only thing I hear, data, 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 money, money, money. Listen, take it hard what the doctor said to you. When 78% of the employees aren't coming in the office, you don't get much sympathy from us. Rob, it may be the wrong time to do a demonstration project about working remotely. You know, the biggest struggle we've got is putting people back in the office. Congress did it. Government's not capable of doing it. Private sector's struggling with it. Post-COVID is very different. But the responsibilities that you have as the emergency response components haven't changed. You've got to look at your workforce. You've got to look at the challenges. You've got to look at the procedures that you got in place and say, have we really learned from the last one? Now, I'm not going to be here to see you probably again. I'm not sure Patty will hold another hearing before now and the end of the year. But I want you to know I've looked forward to working with you. And I will continue to be a resource to any of you because I only have one goal. And that's that I know for the next one, we've got to respond a hell of a lot faster than we did for COVID, and we've got to do much better than we did on monkeypox. Because on the other side of this, potentially is one that gets out of control with massive amounts of loss of life. Mr. Chairman, I thank you for your indulgence. I probably missed the vote, but that's okay because I think this is more important. I yield back.
Thank you very much, Senator Burr. Thanks to all the members of the committee for participating, to all of our witnesses, Dr. Walensky, Dr. Fauci, Dr. Califf, Ms. O'Connell. Thanks for this really important and thoughtful discussion about the response to the monkeypox outbreak. For any senators who wish to submit additional questions, the record will be open for 10 business days. The Help Committee is pretty generous, 10 business days. So you got until September 28th at 5 p.m. for additional questions for the record. And with that, this committee stands adjourned.